Hello everyone. We'd like to welcome you to this webinar on integrating heat adaptation with climate and disaster plans at state as well as national level in India. It's a real pleasure to have with us here by video, a video address by Dr. John Balbus, Senior Advisor at the National Institute of Environmental Health Sciences, United States. We would also be having with us three very eminent speakers in this field. Dr. Peter Berry, Senior Policy Analyst at Health Canada. We'd be also joined by Dr. Vikas Desai, Technical Director at the Urban Health and Climate Resilience Center at Surat in India, and also Ms. Suruchi Badwal, Associate Director, Earth Science and Climate Change at TERI, the Energy and Resources Institute out here in New Delhi. This will be a very interesting webinar, essentially because this not only has experts from the areas of the interface of the climate and health, a newly emerging field globally, important especially in developing countries like India, which are highly vulnerable. In this, we will go through each of these presentations, and you'll have opportunities to question them about the respective topics. So before we go on to that, I'd just like to make some points regarding logistics. Unfortunately, Dr. Anil Kumar Gupta, Head of Division of Policy Planning at India's National Institute of Disaster Management, will not be able to join us because of a very pressing engagement. So he regrets that, but we hope to have him with us in the future. Of course, but besides that, we will be having all the other speakers. You can send in your questions for the speakers through a chat, which will, and those questions will be answered at the end. So, having said so, we can now go to the video address that we have by Dr. John Balbus, and then go further from there.
Providing the infrastructure for the webinar, and to Taru and Dr. Vitashtara for recording this webinar together. The NIH, or also the National Institute of Environmental Health Sciences, is one of the 27 institutes and centers that make up the United States National Institutes of Health. Our institute is very unique in that, first of all, we're not located in Maryland, we're located in Research Triangle Park, North Carolina, co-located with the major laboratory of the United States Environmental Protection Agency. And unlike most of the other centers and institutes of the NIH, our primary focus is on public health and prevention. And we have a wide variety of programs that support that mission of public health, ranging from extensive on-site intramural laboratories with researchers, a clinical research program, as well as a large extramural funding program. The NIEHS is very proud to be able to support the community of practice that we call Understanding Climate and Health Associations in India, or UCHAI, the sponsor of our webinar today. Our shared goals are to build capacity in India to be able to adapt to climate change and its health impacts. And our community of practice is working together in a number of ways to build this community, to bring people in and raise awareness about climate change and health, to conduct training such as webinars like these, and to support the development of tools and community engagement and research collaboration by working with partners both across India and around the world. I wanted to describe for you today one of the major United States efforts in the development of heat adaptation plans. It's called the National Integrated Heat Health Information System, or NIHS. And NIHS is it's called national, and it has a lot of focus within the United States, but at the same time it's an international network. It's just getting going to be able to set up the infrastructure to do this kind of information sharing and to pull together partners around the world at the local, the state, and the national level to share best practices, to look at ways to share data and to improve the effectiveness of heat and health adaptation plans around the world. And this is just a conceptual framework of NIHIS that shows how the network aims to connect at all these levels of government, from the highest level of international networks, working with the World Meteorological Organization, with the Global Framework for Climate Services, all the way down to working in neighborhoods and municipalities on creating community interaction, working with communities, and putting the programs into place. And for those of you who'd like to find out more, a lot of the available resources developed by NIHIS and used by NIHIS can be found at toolkit.climate.gov on the U.S. Climate Resilience Toolkit, such as the Successive Heat Events Guidebook, which was created by the United States EPA to give local public health officials background information on extreme heat events. I'd like to close with just a few observations about heat early warning systems. The experience in the United States is that even within our country, there's a lot of variability in thresholds and the shape of the dose response curve. So while approaches can be universal, the actual data needed to be able to determine when to give warnings and what the likely effects are very local, and there's a real need to collect this local data. But these early warning systems appear to be effective. This is one recent study looking at the effectiveness of early warning systems around the world. And of the 7 studies that were found in this systematic review, 6 of them asserted effectiveness. They looked at different measures of effectiveness, so they weren't able to have a meta-analysis. But you can see on this slide some of the results that they have highlighted, especially what happened in France after the 2003 heat wave and killed so many tens of thousands of people in France and Western Europe. This study cited a follow-up that showed that heat adaptation planning in France mitigated greatly the impacts of a subsequent heat wave in 2006. So with that, I'll close, and I look forward to the rest of the webinar. I'm sorry that I can't be listening in person, but I will be very excited to hear the recorded webinar, and thank you all for your participation today.
Next, we go on to Dr. Peter Berry, Senior Policy Analyst with Health Canada. Dr. Berry has more than a decade's experience working on the issue of heat adaptation. He has pioneered this work in Toronto and the rest of Canada and in Canada, and the lessons that we have for heat are something that we have internationally we have learned, not just in the West, but also in developing countries around the world, and basically the essence of it is that we have now moved from looking at heat as an issue which kind of bothers us or has been with us for a long time, but now with the uncertain climate is something which needs to be dealt with at a professional level, and something where heat management needs to really be looked into. And so that's the sort of those are the sort of messages we will probably be listening, we'll probably be learning from Dr. Berry, and a whole lot more. So with that, I'd like to welcome him to this program, and thank you so much for helping us understand the international context of heat adaptation, Dr. Berry, with special reference to Canada.
Hi, this is Peter. Can you hear me all right, Nitish? Yes, we can hear.
Wonderful. Well, thank you very much to TERI and to Dr. Dogra for the invitation to participate in the webinar today. Participation in this Heat and Health Initiative of India is really of great benefit to the Climate Change and Innovation Bureau at Health Canada, where I'm from, because of the opportunity to share best practices and learnings. The mandate of our office is to increase the knowledge among Canadians of health risks from climate change, including from extreme heat events, and facilitate efforts to adapt. Next slide, please. Much like India, many communities in Canada face a range of health risks from climate change, and this figure shows the results from a recent National Impacts and Adaptation Assessment from climate change. And so you see that a key risk facing Canadians from coast to coast are the health impacts from extreme heat events. But we do have others in terms of vector-borne diseases, mental health impacts from things like droughts and waterborne diseases and such. Next slide. And we know from climate projections that risk from heat illness and death in Canada will continue to increase as climate change continues. And we know this to be true for several major cities that have large numbers of vulnerable populations, older adults, infants and young children, people with chronic illnesses, the physically active, and people of low socioeconomic status. Next slide. And our office, with provincial and local government representatives and researchers, have developed a best practices framework for developing heat alert and response systems for Canadian communities. And this is an image of that framework, and it helps in directing the development or the improvement of these systems in Canadian communities, including the creation of alert protocols or triggers, community response plans, communications plans, which are so important in heat systems, and also evaluation plans. But it also speaks to efforts to take a preventative approach, for example, reducing the urban heat island effect. Next slide, please. There's actually a number of mechanisms that public health and emergency management authorities in Canada are using to take actions to reduce risk to extreme heat. And this is with a wide range of partners. And so they include climate change and health vulnerability assessments, all hazard emergency plans, actual climate change action plans, and national heat health programs, but also healthcare facility resiliency tools. And in the next few slides, I'll provide some examples of these types of actions in Canada. Next slide, please. At the community level, the Public Health Unit in Middlesex, London in Ontario undertook a full climate change and health assessment to prepare for climate change. So assisted by our office, this included examination of future air pollution health risks, vector-borne diseases like Lyme disease, flooding, but also extreme heat. So current risk from extreme heat, but also projections. And importantly, they looked at the effectiveness of some of their adaptations or risk management measures to get a better sense of vulnerability. And the community of Leduc in the province of Alberta included heat waves as a priority health risk in its all hazards weather and climate readiness plan. And so this plan is helping officials at the city level really control for the impacts of weather and climate hazards on their operations, which is really quite important. And at the provincial level, Ontario has included efforts to address heat health risks in its climate change adaptation strategy and action plan. And so this includes efforts to raise awareness about health hazards from climate change, including from extreme heat. Also to develop climate indicators, so for example, the number of heat alert days in communities, and also create a heat vulnerability tool for communities to use. And I understand this strategy or this plan is being updated. And at the national level, our office at Health Canada is leading an initiative to increase the resiliency of Canadians to the impacts of extreme heat events. And we're doing this by developing heat health messaging to support personal adaptation, conducting research into heat health science gaps to address some of these knowledge needs, disseminating information to healthcare workers through clinical training, and expanding heat alert and response systems to communities at risk across Canada. Now, whatever mechanism is used to protect populations from heat health risks, this really needs to be accomplished through wide partnerships. And so this figure shows some of the many partnerships we've developed through our national program in collaboration with our colleagues at Environment and Climate Change Canada. So we've worked with health officials out in the western part of Canada and British Columbia, in the prairies, in Alberta and Manitoba, in the province of Ontario, in Quebec, and in New Brunswick. So the partnerships are really very, very important. And as John Balbus mentioned, the research and the surveillance is incredibly important to provide the evidence to inform these types of activities. Our office continues to work with and learn from our partners, including in this case, the province of Quebec, in developing and disseminating these research results. We've also benefited greatly from discussions with colleagues in the United States as they roll out their climate change and health program and activities. So in closing, I've included a reference to a number of resources on heat, extreme heat and health that are available on our website. And I just want to, again, thank you kindly for the opportunity to participate in the webinar today. I know extreme heat events are going to continue to be a major challenge to human health, especially with in the context of climate change. So I really wish you all the best for continued efforts in your efforts to reduce health risks in India.
So thank you, Dr. Berry. That was very interesting. And next, we will be moving to Ms. Suruchi Bhagwal from TERI, and she will be speaking to us about the linkages between health, adaptation, and climate. So how do we do this integration of our work on heat adaptation in the health sector to climate? And she has almost 2 decades of experience on climate change, with several years of experience in the health sector also. So she is very, definitely very competent to answer on this area, particularly because she is also part of the newly constituted committee of the Health Ministry, which deals with the health mission as part of the National Action Plan for Climate Change, which is one of the newer missions that has been introduced. And she will also be referring to what has been the plan there on how health is being mainstreamed in the climate agenda, and also heat as part of health per se.
Good afternoon, everyone. First of all, I would like to thank Saru for giving me this opportunity to present on this topic. I will be focusing my presentation on national, subnational integration of heat-related concerns into policy and practice. And to be able to relate to the topic that I have chosen for the discussion, I will start my presentation with the reason for concerns. Basically looking at the changes in global temperatures. This is a figure from the IPCC report, basically indicating the range of temperatures we are likely to expect in future time periods, spread over the next few decades up to 2100. And if you look at the projections, all the projections are positive, and the range that the various scenarios indicate basically start from 1.1 degree centigrade extending up to 6.4 degree centigrade, and we could actually lie anywhere within this range in terms of changes in temperatures that we're expecting, both maximum, minimum, and across different seasons. Of course, these changes in temperatures are associated with changes in precipitation patterns, a whole range of other changes, if I were to say evapotranspiration rates, humidity levels, and increase in the frequency intensity of extreme events. And therefore, there's a cause of concern to health-related, the impacts on health. The impacts on health, basically, taking some inputs from the IPCC again, basically indicates that by mid-century, it is projected that climate change will impact human health, mainly by exacerbating health problems that already exist. So we are already experiencing certain stress, and this may exacerbate in the coming few decades, and throughout the 21st century, climate change is expected to lead to increase in the ill health in many regions, and especially in developing countries with low incomes, as compared to the baseline without climate change. And that is because, the infrastructure, the health infrastructure, etc., are not up to mark and up to date in these countries. And examples basically include greater likelihood of injury, disease, and death due to more intense heat waves and fires. And there are examples of it that we see in the developing world. There are examples in the developed world also. But living in the tropics, I think this hits us more badly in India compared to other parts of the world. At present, the worldwide burden of human ill health from climate change is relatively small compared with effects of other stresses, and it is not well quantified. So we have some degree of information, but we still need to work a lot to be able to kind of complete the loop and have a better understanding on how health is affected because of changes in the climate. However, there has been increased heat-related mortality and decreased cold-related deaths in some regions as a result of warming, and this is well documented through certain examples and media reports that we have. There are impacts from recent climate-related extremes that we see. We have documentation of deaths due to heat waves and effects of other extremes. There are direct impacts in terms of mortality and morbidity that we have experienced across different regions because of extreme heat, and basically affecting particularly vulnerable people, those who are working outdoors in urban or rural areas. The main factor that basically affects human discomfort is a combination of temperature and humidity, and therefore, since both these factors are likely to change in future time periods, therefore human discomfort and heat-related stress is likely to increase, leading to heat-related mortality and morbidity. This is just a snapshot for India, basically indicating the nature in which the temperatures are likely to change, and we see most of India, there is a vast change in temperature patterns that we expect in future time periods. Similarly, precipitation is also likely to change in the same manner, and therefore humidity, which is linked to it, is also likely to vary. This is just a case study for one of the states, and we see how it's a heat index basically done for one of the states in India, where we try to combine temperature and humidity to look at the human discomfort and impact on health, and how is it likely to affect people. And this is basically using a certain methodology adopted worldwide in terms of looking at the human discomfort given the combination of temperatures and humidity patterns. And we see most of one of the states that we tried to study, which is the previous slide, basically indicates regions lying in vast degrees of human discomfort related to heat. Now, as a result, and of course, this is a slide of this year wherein there are media reports indicating number of people affected by heat waves across the country and the number of deaths that we have experienced this year because of heat waves. And of course, we know that the frequencies of these events have been increasing over time, and they are likely to be far more grave impacts that we are likely to experience because of these. So the call of the day is basically to integrate health heat-related concerns into policy and practice. Adaptation as such is becoming embedded in some planning processes, if you were to see, and Nitish mentioned, as part of the National Action Plan on Climate Change, we do have a National Mission on Health, which is now being drafted. And though, it is in the planning process, it's in the draft stages, we are still not there in the sense that implementation has not begun, and therefore there's a long way to walk yet in terms of achieving something. In terms of the elements that one would look at related to heat-related stress, the important elements would be related to the implementation of warning systems, adaptation of the dwellings and workplaces and of transport and energy infrastructure, reductions in emissions to improve air quality, improved wildfire management, and development of insurance products. On heat health related warning systems, basically the approach could be to look at urban planning to reduce heat islands, landscaping approaches, improvement of the built environment and the way buildings are structured, development of sustainable cities, which may encompass areas of landscaping. Looking at building insulation, very simple methods of using gunny bags to enhance cooling, because if you were to look at different sectors of the society where people have access to services, infrastructure, vis-a-vis those who don't have, I think simple methods would be more effective. And basically promoting new work practices to avoid heat stress among outdoor workers. So in a nutshell, basically summarizing, there's a need to strengthen monitoring and surveillance for climate sensitivities. And the reason for that is basically that we lack good quality and high resolution data set, which makes it difficult to generate precise knowledge on the probability of occurrence of such incidences, and therefore we need more data, information and knowledge on the occurrence of such incidences and its impacts. So we need more stories to relate to. And what can be done once we have the information is to set up the right kind of systems, infrastructure to be able to deal with those, and the right kind of policy incentives and practices that can be introduced to deal with it. The second thing that I think we would need to basically take care under the policy and practice is basically to have methods in place to prioritize vulnerable regions and population groups for targeted interventions to address heat-related risks. This would be important because we have limited resources, and therefore we need to channelize the resources in terms of how we are implementing our policies and practices, and therefore this would be a great aid in terms of supporting decision makers in terms of targeting interventions. The third thing is basically to have proper systems in place to be able to assess the risks that we face. Say, for example, we could develop modeling systems tools which can act as prompters when thresholds are crossed, and warnings can be issued to people. So that, rather than have a reactive mode when a disaster has struck, we could have a precautionary approach in terms of having certain systems in place which prompt us to take action, and the policies could actually be structured in that way in terms of assisting in the process. The last point is basically to build capacity of relevant people, and the most important would be the health sector staff, because under such cases, basically, what you observe is, when the heat waves strike, there is a sudden increase in the number of cases being reported to hospitals, and therefore there is a need for the health sector staff to be made aware of such situations and how to be prepared during such situations. Practical trainings could be organized for them in terms of being how to be structured in such situations when if there's an increase in the number of cases being reported to them. Also, in the end, I would just like to conclude a very simpler way of doing this is to have a list available to all relevant people, including the community, on the essential do's and don'ts for various type of cases. That could be there. It could be developed and it could be shared for spreading of awareness related to heat stress, stroke cases, and severe dehydration. And this could be widely disseminated for raising public awareness. So, mass awareness campaigns could be launched, introduced, and different sources of media could be used to spread the word. And policies could actually kind of integrate this into them to be able to make it one of the agenda points to kind of reduce the risks related to heat stress. And I would just end there and basically invite your questions. Thank you.
Thank you, Suruchi. That was most illuminating. So we will be inviting in questions, and then we'll be answering all of them at the end. So now we basically move on to the next speaker, who's Dr. Vikas Desai, Technical Director of the Urban Health and Climate Resilience Center in Surat, in Gujarat. Uh, Very briefly, the Urban Health and Climate Resilience Center, Dr. Desai will be explaining in detail, but that is a first of its kind center which is looking at the specific linkages between urban health and climate change. And it's a project which is funded by the Rockefeller Foundation, and now a larger program where different stakeholders in Surat are working. Dr. Desai has a very long history of working in the city of Surat. He's a former professor of community medicine, has worked with the directorate in Gandhinagar in Gujarat as the head of reproductive and child health. And she comes with almost 40 years of experience in the whole field of urban health, climate change, and disaster management. And it's really a pleasure that we have with us somebody who comes with this encyclopedia of knowledge and experience, who will be speaking about this whole area, and she will be talking about the operational issues that are linked to heat adaptation plans in the city of Surat, the lessons from Ahmedabad where the plans were carried out earlier, and what it means in Gujarat and the larger national context. So we welcome you, ma'am, and over to you.
For Surat city, but before I do that, I struggled to prepare this plan. If I go to next slide, which shows the comparison of Ahmedabad and Surat, it shows that both the cities, which are only 250 kilometers away from each other, have a different profile in terms of Ahmedabad being a dry and arid region, and Surat is a coastal city, and impact of heat wave is not very visible in Surat city unless you analyze the data. So it's a hidden result. While in case of Ahmedabad, the morbidity, mortality are well perceived. And if you can see the April, May and June are the peak period, and where we get a high temperature as well as the heat stress cases are observed in city. Ahmedabad started first with heat action plan, which was the first heat action plan in Southeast Asia, and then we launched through that, and we prepared first coastal city heat and health action plan in Surat, and the first phase was piloted in 2015. The next slide shows the diurnal variation in temperature, which is a major deviation between Ahmedabad and Surat, and probably that explains why Ahmedabad is documenting more morbidity and mortality. Within 24 hours on same day, we can see the Surat, there is a peak between 10 to the peak is at 1 o'clock, but there is a higher trend between 11 to 3, and then it goes down. That means it cools down. On the other side, Ahmedabad remains hot for a long period, maybe for hours together, and that's how there is a longer duration cumulative exposure to higher temperature, which probably is influencing health of the people more. And as it was reported and analyzed, Ahmedabad analysis showed that there is a 45% increase in mortality when the temperature rises at the level of heat wave, while in Surat what we observed was if we take only heat into consideration, maximum temperature, then it is 11% increase, that means 3 deaths more than the per day. While in case of heat index, because we are coastal city with high humidity, we saw 6 more deaths per day in Surat. Going to the next, again this is a very typical next slide, which shows the spatial pattern of heat and humidity in Surat city. And the left hand side, it is a west part of the city, which is seashore area. Can I go to next slide, please? Which shows, which has on same day, same time, these temperatures were measured, and it shows that there is a difference of 4 degrees Celsius between two extreme zones, that is seashore area and the zone which is far off from the seashore. And that's how within city we have a high risk zone in terms of humidity and temperature and heat index, which is very clear from this slide. And that also has shown influence on the all-cause mortality when we analyzed spatial data of the climate and health. Going to the next information, I would also like to little bit talk about what is the situation of urban health system in India. We have a National Ministry Health and Family Welfare Department which provides funds and which also gives guidelines for operationalization of national health programs as well as for the National Health Mission, which is the recent fund which includes Urban Health Mission too. And then all guidelines and the prioritization of the programs are done through the National Ministry, and states follow that. Partial funding is also provided to the states and the state also spends on that, and then state also operationalizes the national program as well as state health programs. There are some which are state initiatives. Following that comes the district or a city, big city like which is operationalized, which is managed by municipal corporation. So they also follow this national and state level programs, and then comes the local initiatives. Surat is a city, next please, city which is typical in terms of, Surat is a unique city where we can say the health challenges brought the governance reform, and that is how it is more remembered and memorized. A city with a very rapid population growth, high migration, low sex ratio, almost 30% population in some and slum-like area, and rapid industrialization, which are these socio-demographic risk factors for the city. Against that, there is a comparatively good governance. It is smart city, 100 resilient city. Infrastructure is quite well built up. Public transport is one of the weakness. We have very poor utilization of public transport. Alternative energy, water recycling projects, because the climate resilience is the priority for city, are in place, and it has relatively well designed urban health system. Against that, there is last 30 years data analysis shows that there is a rising temperature in the city. Even people have experienced that, and we have analyzed, and our analysis shows 0.7 degrees Celsius increase in the maximum temperature in the last 30 years. Humidity also has increased by 30%. If we look at the on right hand side, the disease profile, non-communicable diseases have significantly increased, road accidents have increased, malaria has gone down, dengue cases are coming up, gastroenteritis and diarrhea cases are getting less, but infective hepatitis cases are increasing. Surat is on the higher rank of HIV positivity, though the overall incidence rate has gone down. Two rodent-borne infections, plague and leptospirosis, have emerged in the city after flood, and child mortality is showing declining trend, and there are no records of heat morbidity in the city. Going to the process which we underwent to prepare a heat action plan, we learned from the process which was adopted by Ahmedabad city, which was the first attempt, and NRDC and the Public Health Foundation of India, Gandhinagar was our mentor for this. We prepared, first we analyzed every year's climate data as well as the all-cause mortality data, followed by practitioners study to just learn whether doctors are seeing any cases of heat morbidity and how they are managing these cases and reporting these cases, public and private system both. We also worked with the community to understand whether community have experienced any untoward influence of rising temperature, as well as what are their practices which they have adopted, which we can also incorporate into the action plan as a community experience and adaptation. And then all three together we converge into the action plan. And as rightly quoted by the Ahmedabad Municipal Corporation Commissioner Sri Mahapatra, this heat action plan provides the roadmap we need to save lives when the next dangerous heat wave hits to the city. So that's how we prepared our heat action plan for coming untoward events. The heat action plan of Surat was into two phases. We have completed phase one, which was only for the institutions, that is medical care institutions. Surat we wanted to go little slow because it's not visible morbidity. People are not rushed to institutions for care. Only when we analyze the data, we get the information that there are more all-cause deaths during the heat wave period, 2 days subsequent lag period, as well as the summer trend. So that's why politically, administratively, and for the community confidence sake also, we decided to go phase 5. So first we worked with institution as well as community-based intervention. And what was done was evidence-based local planning. What is more important here is ownership of the local self-government. The research institutions, centers like ours, we create an evidence, but then municipal corporation has to accept that for implementation. And one of the challenge here is that even today, the heat or the climate is not the agenda in the health. And that's why the health programs don't talk about climate. Research does talk about climate and health. And that's why it's important that the local advocacy is stronger to motivate the local administrator to adopt the action plan. But we also have included the multi-stakeholder participation, that means water supply, gardens, all related departments who can contribute to the comfort, who can contribute to minimize the impact of heat on the human beings. Then we have taken integrated approach, monitoring and revised planning scope is continued. We also have gone for public-private partnership involving private medical practitioners also with sharing the information, dissemination of the data with them. Community participation will be in this year a part of intervention, media, community as well as media participation. And the involvement of academic institutions is the next thing, because we need to prepare future generation as well as we need their support, all academic institutions like engineering faculties, like health faculties, like social science faculties, to learn, get oriented to what we have observed for the sustainable interventions in time to come and to contribute to it further through research. I would also like to share information about the institutional arrangement. Ultimately, for human health, it is more a prevention which works in case of the heat stress, and we have divided that into 3 groups. Hospitals also request, our hospitals are not air-conditioned hospitals, there is overcrowding. Intra-ward comfort zone needs to be taken care of, and that's why what we suggest is that the intra-ward or building comfort zone should be ensured during summer, we need to improve patients' hydration. Even this is important because summer is the phase when there is a water shortage. Maybe it is not attended to by the institutions. Especially public hospitals, big hospitals have large number of patients inside as indoor cases, and then they need a special care. We also train nurses to ensure that the patients regularly take the water, who are reminded to take the water to ensure dehydration. Case management protocols and skill building is next action which we try through workshops, and case records and documentations are important to learn and understand what happened in relation to intra-board environment and the temperature. Then outdoor clinics, case management and referral protocols were prepared, skill building workshops were done, and case records, all these case records are under analysis. At community level now, in time to come, we are proposing action for intra-domestic comfort, ensure oral hydration of all with care of senior citizens, children, pregnant and postnatal women, those who are exposed to direct sunlight due to their occupation, and then early warning system in place, which people can understand, laymen can understand. I would also like to add here that the community level action, as it is known to all, poor community suffers more. Their housing condition is such that their discomfort level is more rich. If space is more inside the room, they also need to get enough attention and information in time to come. Coming to our experience of working with this plan, one of the things is we believe that though Surat and Ahmedabad has kept health department as a nodal office, to have a good collaborative action, we need to prepare health as well as the engineering sector and guidelines separately, and the responsibilities given to the head separately, so that both are attentive to the requirements of the city. And this is what we have done. The first phase experience was good. Doctors were very cooperative institutions, also arranged for the additional water supplies, drinking water supply and the comfort zones for the hospitals. And we are hopeful to implement the phase 2 in coming time. And that's what Surat experience is. Questions are most welcome.
Thank you, ma'am. That was very interesting. So yes, questions will be coming up. So first, I'd like to invite Suruchi for the questions that were can be answered by her best on the basis of her expertise. So over to her.
I'm going to take some of the questions that have been posted, and I think we distributed the questions amongst us in terms of answering them. So the first question that I would be addressing is on why many climate adaptation plans fail. Frankly speaking, it would be too premature to actually say that these plans have failed. These are just being structured, some of the plans have been made maybe in the last 5 years or so, if you look at other countries. And even the plan in the context of India, it's just in its draft stages. So it's getting formulated, and therefore, once it is formulated, would basically the implementation plan roll out. And I think we will have to give it some years to be able to say whether they've failed or we've been able to achieve certain things or not under the plans that have been outlaid. So I would leave it to that. We are in the process of making the plans. We do realize the risk, and therefore, how do they get implemented? Something we'll have to observe over the coming years. The next question that I would pick up is, this question related to what can be the role of community radio in terms of disaster preparedness. Definitely there's no second question about their role because of the reach they have in different areas. In many cases where you're not able to reach people in remote areas, this is the most effective mechanism that is used to communicate information to people. I am actually, frankly speaking, I'm not aware of community radio being used to as an early warning tool system in early warning tool system in remote areas, but it can be used. So there is potential to use this as a tool. Right now, community radio is being used for various purposes. Most of the dissemination through community radio is done for the agricultural sector, keeping in mind the farming community and practices that need to be promoted. But I think it can be used effectively for other sectors as well, in case of the health sector, especially in the context of heat waves and even cold waves, I would say, one could use this as an effective tool. The second question, third question, which is actually I think is related to the previous question, wherein I think you are asking on how could we actually use effective methodology to spread the do's and don'ts. And I think we need to have a mix of methods to be used to spread the do's and don'ts. I think in urban areas there are other things that may work. There are other faster ways of reaching information to the people. In the rural context, definitely you will have to explore what means and practices work. For example, you could route it through the formal system. You do have health centers at the district, at the block, at the village level, where you have the primary health centers. So, information could be passed on to them to reach to the community. But then you can use, as why the previous question is linked, is because you could use tools like the community radio to also reach the information to people. I'd move on to the next question, which is, I think, particularly addressed to me if I go down further. I think this is basically related to, if we would have collected data in April, May, was there an opportunity to obtain good quality data on mortality, morbidity, and match it with meteorological data? Now, unfortunately, you have a very good, rich data set on the meteorological side, but when you start looking at data on the health side to collect information related to a particular area that you're trying to investigate, I think what we find are huge gaps in terms of the kind of data you require to do such assessments. And that is why one of the points in my presentation was to set up a surveillance system and have a system in place for monitoring and collection of such data which is relevant to this kind of research, which can help us in a proper action plan being laid out and integration into policy and practice. So what is required is setting up systems related to certain certain health related concerns on the type of data that needs to be collected, and then who collects the data, at what scale is the data required, etc. And that level of detailing we have not gone into. So therefore we need systems in place which allow us to collect the data in that form and format that will allow us to do those assessments, to be able to basically see the linkages effectively and also take our research forward in terms of doing something about it in this area. This question links to the next question actually, where someone has asked that could you collect such quality data in rural areas? Frankly speaking, we are lacking collection of that information data even in the urban areas. The rural areas, it's a far more difficult cry. But since we understand that there are these linkages and we understand systems are not in place, I think this is an opportunity that we see where we need to create such systems, both in the urban context as well as the rural context, to be able to collect that information data, to be able to convert it into knowledge enough to take action. So I think the objective aim would be, how do we target all areas? Normally in the case of heat waves, when we talk about exposure to heat waves, while in the urban context is being discussed, there are greater implications in the rural areas also. So therefore you cannot ignore the rural areas, and we need systems in place for rural areas as well. And I would end with that. Thank you.
We now go on to the questions to Dr. Peter Berry. So one question we had was, there are many types of heat index, but why have you chosen heat and discomfort index in your work? So basically the question is on heat index and what kind of indices are used for that. So,
in terms of the heat indices, there's a wide range that are used in Canadian communities. So some just use temperature, some use temperature and humidity, and in fact there have been some communities that include air pollution in terms of when to call alerts. So in fact, one of the challenges that we have had is that, for example, in Ontario, there were a number of different communities using different alert protocols based on these parameters, and so it was actually confusing the public sometimes when the alerts were called, or the stakeholders, the people that needed to respond and assist vulnerable populations. So there's actually a major initiative in Ontario, and they've had a lot of progress in terms of harmonizing the alert system so that a specific index is used. And that was thought to be very, very important to increase the effectiveness of the various systems in the communities in Ontario. And so they developed working groups like a science working group and a governance working group and a communications working group to make sure, again, that some of the communications and messages going to vulnerable populations were coordinated and also were consistent, weren't contradicting each other. So this has been a really important area, but I can certainly send you a bit more information on some of the specific indices by email for sure.
Right. So next question we have is which basically is in relation to the heat island effect, and the question is that how can we reduce the heating in the urban areas, and what can the government do about the planning aspects in relation to heat?
And that one's for me, Nitish?
That's the question.
Okay, thank you. So our office at Health Canada has been quite involved in efforts to help communities reduce the urban heat island. So we've developed a compendium of various measures that can be used in terms of cooling. So, greening communities, different types of building materials that reduce the heat overnight so that communities cool. But what's really important is that we have supported some case studies or pilot studies in communities so that people can see what's most effective in terms of these measures. And so we've done that in a number of communities in Canada. And so they're learning from each other in terms of how to do that. So we have a number of case studies that we can share about how communities have done this. And one last issue is it's really important to have a good sense of where in the community the heat is a problem through spatial mapping or through a vulnerability assessment. So in Windsor, Ontario, they did a heat health vulnerability assessment to get a sense of where in the city people were most vulnerable. And then they developed a sort of an urban heat island reduction plan based on that assessment and implemented a number of these different measures. And I think they found that was quite helpful.
Thank you, Peter. Now I'd just like to take one last question for Dr. Desai, and there are several other questions, so you are most welcome to ask those questions to the email that is provided. So we just get that question to you. Yes. So the question basically that was posed by a listener was that now even in India, it is possible to get good quality data for health in urban areas, and that has been demonstrated in Surat and Ahmedabad. So, but in rural areas, this is a challenge. So, how can this be overcome? Basically, this whole data issue, what can be done in rural areas?
One thing is we do need to start looking at data in terms of need for the climate impact assessment. Now, even in Ahmedabad and Surat, the all-cause mortality was used to analyze the impact and relation between the heat wave and the mortality and its severity. And I think almost all big cities have a computerized death registration system. It needs to be analyzed properly from the source, and it's time now to think about the observatories which can be supportive to municipal corporations, because they don't have such epidemic cell or epidemiology cell which can continue to work for them. So a unit which analyzes the data and converts these figures into health information for municipal corporations. So it's the fact that the type of data which is available for climate is not available for the health as of now uniformly standardized. But then we need to accept that challenge and try to build up this information in a whatever minimum is doable in time to come.
Thank you very much, ma'am, and thank you, Dr. Berry. Thank you, Suruchi. So it was really nice that you shared your knowledge and experience with everyone. We have had so many questions, and we will definitely answer them. And we hope you enjoyed this whole the session. And please give your feedback. That will help us to improve this engagement method that we have, and we will continue to have several more down the road. Thank you.